Hello friends, today we will see second lecture of pulmonary function test, that is diffusion study or transfer study, otherwise called DLCO. So in this class we will discuss about physiology of diffusion, various terminology like KCO, DLCO, VA, measurement of diffusion capacity, about technique, how to measure DLCO, and of course importance in respiratory diseases, in which condition DLCO reduces, in which condition DLCO increases. So regarding terminology, there are two terminology: diffusing capacity, otherwise called DLCO, and transverse factor, TLCO. These both are same. In European countries, it is called TLCO. In American countries, it is called DLCO. But the right term is transverse factor. I'll tell you why. Because in diffusion, we are looking the rate of transfer of oxygen from alveoli to blood. Okay, so this is transfer of oxygen, not diffusion, transfer of oxygen from alveoli up to hemoglobin, because it check, it estimate the transfer of oxygen from alveolar gas to red cells. Oxygen coming from environment, coming to trachea, alveoli, from alveoli to blood, and blood to hemoglobin. In this manner, this gas exchange completed. So why we are checking for oxygen, why not for CO2? Because CO2 is very soluble to membrane. It doesn't depends on diffusion. So it depends on mainly on ventilation, while oxygen depends on diffusion. CO2 is very soluble. If we remove 50% of alveoli, then also CO2 will wash out because of ventilation. So we need to check diffusion. That's why we're checking diffusion for oxygen. Okay. So diffusion of oxygen from alveoli to blood, it depends on many things. Main is alveo alveolo-capillary membrane. So this is alveoli, this is capillary. So alveo-capillary membrane. So if we want to diffuse more oxygen, we need large surface area. So diffusion of oxygen from this capillary, alveolo-capillary membrane, depends on surface area. More is the surface area, more is the diffusion. Thickness. Okay. So thickness of this membrane, alveolo-capillary membrane. If there is more thickness, the diffusion will be reduced. If less thickness, this easy for oxygen to diffuse through this alveolar membrane. Another thing is diffusion of oxygen depends on amount of blood in pulmonary vessels. So this is pulmonary artery, pulmonary capillaries, blood is flowing through this capillary. Okay. And this capillary has oxygen which is being exchanged with alveoli. Okay. So large amount of blood means large amount of diffusion of oxygen from alveoli to blood vessel. Another thing is amount of hemoglobin, because oxygen has to bind hemoglobin for circulation. Once it will bind to hemoglobin, then it will transfer to other organs, other tissues. So amount of oxygen diffusion is depends on amount of hemoglobin. More is the hemoglobin, more transfer of oxygen from alveoli to blood. So let's see diffusion study, or otherwise called transfer test. So what is this diffusion study? So diffusion study is lungs ability to transfer carbon monoxide from alveolar gas to hemoglobin in the blood. Though we are checking diffusion for oxygen, but we are not using oxygen for study. We are using carbon monoxide because it freely diffuses from alveoli to hemoglobin. Okay. So why CO? We are taking carbon monoxide. We are taking other drugs, other gases like oxygen and carbon dioxide, because carbon monoxide is normally not present in alveoli or blood. Okay, while oxygen is there in blood capillaries, so there is partial pressure of oxygen in alveoli and partial pressure of oxygen in capillaries. So there is gradient. So more is the gradient, more transfer of oxygen. If less gradient, then less transfer. Okay. Say for example, the amount of oxygen or partial pressure of oxygen in blood is 40. Alveoli it is 100. The gradient is 60. If we increase oxygen in blood capillaries, say for example 80, in alveoli is 100, the gradient is 20. So in which condition more oxygen will diffuse? When gradient is more in previous one, when gradient was 60. The benefit of carbon monoxide is not is there in blood. So there is no gradient. So whatever carbon monoxide you insert in alveoli, it will diffuse to alveoli to blood, because blood there is no carbon monoxide. So there is no back pressure. Okay, and transfer is diffusion limited rather than perfusion limited. So transfer of carbon monoxide is not depends on partial pressure of carbon monoxide in blood. It is purely diffusion limited, diffusion through alveolo-capillary membrane. Okay, so that's why we are using carbon monoxide. Another thing is it bind hemoglobin with 210 times that of oxygen. If both things are there, oxygen is there, carbon monoxide there. So carbon monoxide 2 10 times more soluble with hemoglobin. If two gases are there, carbon monoxide will bind to hemoglobin very rapidly than that of oxygen. Okay. So whatever carbon monoxide we inhale, it will directly go through hemoglobin without any hindrance. That's why this is ideal gas to see diffusion capacity of a lung, because nobody is stopping this gas, either alveolar membrane or blood or hemoglobin. That's why we are taking carbon monoxide. So if we see physiology, so carbon monoxide transfer depends on membrane conductivity. Membrane conductivity means alveolo-capillary membrane conductivity. How much soluble with this membrane? Because alveoli is there, in that gas is there in alveoli. From alveoli the gas has to transfer to hemoglobin, blood hemoglobin. Okay, so how much solubility is there with this alveolo-capillary membrane? This is membrane conductivity. Okay, more is the conductivity, more transfer of the gas. Okay, another thing is binding of carbon monoxide to hemoglobin. So it has two things. One is chemical reaction rate, how rapid CO bind to hemoglobin, rate at which CO bind to hemoglobin. Faster is the binding, faster is the transfer. So more rate of this chemical reaction rate, more theta, more transfer of gas. Then volume of alveolo-capillary blood. So more is the pulmonary blood circulation, more is the gas transfer. So carbon monoxide transfer depends on membrane conductivity. More is the soluble with alveolo-capillary membrane, more the transfer. Chemical rate reaction, more is the rate of binding of CO, more is the transfer. And more is the blood in pulmonary capillary, more is the transfer. So this is all three is related. So 1 upon DL, diffusion, is equal to 1 upon dm, this is membrane conductivity, and plus 1 upon theta into pulmonary capillary blood. Okay, all three are related directly. So again, by this diagram you can understand this is the area by which gas diffuses from alveoli to blood. So more is the surface area, more is the gas will transfer from alveoli to blood. So depends on surface area, directly proportional to surface area, inversely proportional to thickness. So more thickness, less gas transfer. Okay, if thickness is less, membrane is very thin, then gas will transfuse easily. Okay, directly proportional to diffusion. So more is the solubility of gas to this membrane, alveolo-capillary membrane, more is the gas will diffuse. Then of course pressure gradient. So more is the pressure gradient, more volume of gas will transfuse. So directly proportional. In carbon monoxide, P2 is 0. P1 is the pressure of alveoli. P2 is the pressure of gas in blood. Okay. So P2 is 0 in case of carbon monoxide. That's why we used to take carbon monoxide, because pressure is 0 in blood. So whatever pressure is there in alveoli, which will be directly proportional to volume of gas. More is the P1, more is the volume of gas. So if we see the formula of a diffusion study, diffusion capacity, so carbon monoxide transferred from alveolar gas to blood, which is ml per minute. In 1 minute, how much ml is getting transferred from alveoli to blood, divided by pressure, rather pressure gradient, mean alveolar pressure minus mean capillary pressure in mmHg. So if we technically see, the mean capillary CO pressure is 0 in case of carbon monoxide. So what will be the unit? ml per minute per mmHg. So amount of carbon monoxide in ml diffuses per minute per mmHg in standard temperature, pressure and dryness. It should be constant. STPD should be constant, because the diffusion of gas will depends on temperature, depends on pressure and depends on dryness. Okay, so we have to keep constant this STDP, then only we can calculate as ml per minute per mmHg. This is a very important question for your MCQ in DM entrance examination. Or if you take gas in millimole, then unit will be millimole per minute per kilopascal, and this HTTP would be same. So these two units we have to remember. Now, where to do diffusion studies? What the indication? So indication is differential diagnosis of dyspnea, especially when chest X-ray is normal. We don't know what's the cause of dyspnea. In that case, it is sensitive indicator for lung as a cause of shortness of breath, especially when X-ray is normal, like pulmonary arterial hypertension. Okay, then it is also used to diagnose obstruction like emphysema, restrictive lung disease, ILD, most commonly used in ILD diagnosis as well as see progression. Vascular disease like pulmonary embolism, pulmonary arterial hypertension. In these cases, we used to get diffusion study done. Screening, early ILD, when chest is normal, spirometry is normal, then mild early ILD will show reduction in diffusion capacity. Early emphysema, pulmonary vascular disease, occupational lung disease, drug-induced lung disease, because many drugs like chemotherapeutic agent, antiarrhythmic, say for example, amiodarone. If you are giving amiodarone to a patient, then it will cause lung fibrosis in later life. Okay. So after certain periods, say for example, 3 months, 6 months, 12 months, we have to see DLCO, diffusion capacity, because chest X-ray may be normal, but early changes of fibrosis will show reduction in DLCO. So those patients who are on chemotherapeutic agent which causes lung fibrosis, so DLCO would be the test of choice to diagnose early lung fibrosis. Okay, then follow up. Of course, follow up in patient case of ILD. Once you started treatment, then we have to see the progression or regression in later life, 3 months, 6 months, 9 months. So progression or response in ILD. Assessment of severity, how severe it is. Example in COPD, ILD, PH, because severity of diffusion will well correlated with survival. If patient is case of ILD and his diffusion study is less than 50%, definitely he will have desaturation while on exercise and he will have poor survival. So DLCO correlate with survival. So these are the indication where we should get diffusion study. Then how to measure diffusion capacity? There are methods. So three methods is there, like single breath method is most commonly used. This is the method we are using in our institute. Intra breath method, rebreathing technique. So what are they? So single breath method, we use carbon monoxide in all three. and this is highly standardized because this is old technique, well studied technique. Most of the research papers are based on single breath. The problem is patient has to hold breath for 10 seconds, which may not be possible for patient those who required exercise testing or those who are having severe ILD. They cannot hold for 10 seconds. So in that case, other test may be useful. Another test is rebreathing test. Okay, this was single breath. This was rebreathing, multiple breathing, but it is less sensitive for VA. Okay, VA is lung volume. I'll tell you later. And calculation is not easy, complex calculation. Okay, but if you do rebreathing, that it will provide most accurate diffusion study. But this is very less commonly used. Okay, another one is intra breath. No need to hold breath. Patient has to take normal tidal breathing. In that breathing, the machine will measure diffusion capacity. So breath holding is not required. But the problem is this is new technique, so not standardized. Okay, so we don't know normal values. We don't know, there's no standardization because new technique. So it requires research. Okay, so the benefit is it can be done in those patients who need exercise evaluation because no need to hold breath. Later stage of ILD. So this is benefit for these patients. Okay, so we commonly use single breath hold technique, otherwise called modified Krog technique. So we will discuss this technique in detail. So this is single breath method, also called modified Krog method. In this, we are measuring transfer of carbon monoxide across alveolo-capillary membrane. But carbon monoxide. Okay. So what gas mixture we are using? We are using carbon monoxide. We know very well the percentage is 0.3%. Another gas is inert gas, helium gases, which act as a tracer gas, is 10%. So what's the role of helium? Helium is an inert gas. It is not soluble with alveolo-capillary membrane. It is not getting transfer from alveoli to blood. Okay. So whatever helium we inhale, we should exhale same amount of helium. Okay. So it just measure the volume of gas in alveoli. Okay. So it is used for to measure volume of gas like total lung capacity, like alveolar volume, which is used for transfer of gas from alveoli to blood vessel. 20%, 21% oxygen for normal respiration and balance is nitrogen. So in this, instead of helium, we can use methane and other inert gas like neon and argon. Okay, but in different concentration. But in our study, we are using helium 10%. Okay, so before prescribing this test, yeah, while prescribing this test, we have to give instruction to patient that he should quit smoking at least 24 hours prior to testing because smoking will give carbon monoxide concentration in blood. So there will be back pressure. Normally, there is no carbon monoxide in our blood, but patient those who are smoking, they will have carbon monoxide in their blood, and it will create pressure gradient, back pressure. So it will reduce DLC. Okay, but it is very difficult for patient to quit before 24 hours. At least 6 hours prior, patient has to quit for good result. Then patient has to quit alcohol at least 4 hours prior to test because alcohol will reduce DLCO falsely. Then patient should avoid exercise before testing because exercise will increase blood volume in alveolar capillaries. It will increase DLCO. Patient has not to take a meal prior to testing because once patient will take meal, the blood will divert from pulmonary capillary to GIT. Okay, so it will reduce DLCO falsely. Patient should sit at least for 5 minutes just for relax because if patient will not relax, then it will increase pulmonary capillary blood volume. It will increase diffusion capacity. And supplemental oxygen should be discontinued at least 5 minutes prior to testing. So what is the problem with supplemental oxygen? Because as I told you, carbon monoxide has to compete with oxygen for hemoglobin binding. If there is more oxygen in alveoli, it will compete with carbon monoxide, and diffusion of carbon monoxide or binding of carbon monoxide with hemoglobin will be reduced. It will give false DLCO. So supplemental oxygen should be discontinued. So this is DLCO procedure, how to do DLCO test. So ask patient to sit relax. Okay. Then ask him to take normal tidal breathing, normal inspiration, expiration, normal tidal breathing. Then ask him to exhale up to RB, complete evacuate his lung, complete, complete, complete. Then ask him to take deep breaths, rapid and deep breaths up to total lung capacity. But it should be rapid within 4 seconds. Okay. So you can see here it is RB, residual volume. Patient has to inhale up to his total lung capacity. Okay. Within 4 seconds, not more than 4 seconds. Otherwise, it will give false increase in DLC. Within 4 seconds, he has to take his whole breath up to TLC. Then breath hold for 10 plus minus 2 seconds, 8 to 12 seconds. So once patient has taken breath up to TLC, he has to hold breath for 10 seconds, at least 10 seconds, 8 to 12 seconds. Then after holding breath, he has to expire rapidly. Should not be more than 4 seconds. Within 4 seconds, he has to expire his whole breath. Okay. So machine will take later half of sample for analysis, because once you exhale, the initial part of vital capacity will come from dead space, trachea, bronchi. Okay. So initial volume will be discarded. Dead space should be discarded. Later sample, we have to take this sample after discarding dead space for calculation of DLCO. So how much that gas should be collected? 0.75 to 1 hour. It should be discarded. Okay. If vital capacity less than 2, then washout volume should be reduced to 0.5. Rest of gas we will analyze. Okay. So sample is analyzed for the fraction of CO and helium. Okay. So helium will tell how much volume is there inside the lung, and carbon monoxide will tell how much transfer is there from alveoli to blood. Okay. So for acceptable test, we have to repeat test. But one thing you have to keep in mind, that we have to wait at least for 4 minutes to repeat test. Otherwise, it will increase carbon monoxide concentration in blood, will give false result. So we have to wait for 4 minutes between two tests. We should not do more than 5 maneuver. Maximum 5 tests we can do. We should not do more than 5. And the criteria for two acceptable test is the DLCO should be within 2 ml per minute per mmHg or 0.67 millimole per minute per Pascal. So this criteria should be matched to say that our DLCO is acceptable. Two test is acceptable. Okay. One of most common problem is that patient is not able to take breath up to TLC. Okay. So patient should take at least 85 to 90% of breath of his previously measured vital capacity. Means 85 to 90% of his TLC. Say for example, TLC is 5 liter. So he should take 85 to 90% of his 5 liter, at least 4.5 liter or 4.6 liter at least. Okay. So poor inspiratory effort during testing will lead to less than 85% of vital capacity, which cause reduction in DLC. While testing, there should be no Valsalva maneuver. Valsalva maneuver means expiration against closed glottis. Just to imagine, close your eyes, mouth, and try to exhale. This is Valsalva maneuver. It will cause positive intrathoracic pressure. And because of increased pressure, the blood volume in pulmonary capillary will reduce. Okay, it will cause decrease in diffusion capacity. While Muller maneuver, it is just opposite to Valsalva maneuver. In Muller maneuver, engaged closed glottis, patient has to inhale. Okay, when patient will take inhalation engaged closed glottis, it will cause excessive means positive intrathoracic pressure, negative intrathoracic pressure, and it will increase pulmonary blood circulation. And because of increased blood circulation, it will cause increase in diffusion capacity. So while doing testing, we have to take care of these two things. Now we have to adjust report according to these parameters. So age, gender, height, race. So machine will automatically adjust. But other we have to fill in the report, like hemoglobin. This is the, I would say, this is the most common problem, that the person who is doing DLCO doesn't know about hemoglobin of patient. So if we not see hemoglobin, then it will give false report, because every gram of hemoglobin reduction will reduces DLCO by 7%. Okay. So say for example, patient hemoglobin is 7. So DLCO will be less definitely. So if you don't know about hemoglobin, you will think that patient has less DLCO. So we have to correct DLCO for hemoglobin. Same thing is lung volume, because for DLCO, ventilation should be normal. Okay. One patient who has less ventilation means the air is not reaching up to alveoli. Okay. Once air is not reaching to alveoli, there will be less diffusion. Okay. So those patients who have low lung volume will have false reduction in DLCO. So we have to correct. Then of course carbon monoxide, because I told you that in smokers there is increased carboxyhemoglobin. So whenever there is 1% of increased carboxyhemoglobin, the DLCO will be reduced by 1%. So we have to correct. Then alveolar PCO2, exercise and body position. Exercise, I told you, it will increase pulmonary blood vessels. It will falsely increase DLCO. Body position, a patient lying down supine position, the blood shift from periphery to heart. It will increase pulmonary circulation. It will give false increase in DLCO. So we have to avoid. So most common is correction for hemoglobin. So you can see this example. Patient DLCO is 19, predicted is 25, 76%. So once you don't know hemoglobin, then you will label as 76%, but the hemoglobin is 9. So we have to correct DLCO for this hemoglobin. So once we will correct DLCO for this hemoglobin, the result would be 95%. So one person is labeling as low DLCO because he doesn't know about hemoglobin. The person who know about hemoglobin will give report of 95% as normal DLCO. So this is effect of hemoglobin on DLCO. Now coming to our parameters. What parameters we are measuring? So DLCO, I told you, diffusion from alveoli to blood. Okay, it has two parts, KCO and VA. Okay, what are they? So VA is how much of lungs air is actively involved in the gas exchange between the air and blood. So how much surface area is available for diffusion? Okay. Say for example, if alveolar surface area is 4 liter, 4 liter air is there, then diffusion will be 4 liter. So this is VA is how much alveolar volume is there for gas exchange. Okay, so it will remove dead space, because some alveoli are not functioning, some blood vessels are not functioning. It will remove that. So VA is actively surface area which is available for gas exchange. Okay, so technically in normal individual it should be equal to total lung capacity. Okay, but it is never equal to TLC, because because TLC include whole lung surface including dead space. So if you remove dead space, then it would be VA. So VA is almost always less than total lung capacity because it includes dead space also. So TLC minus VA gives estimate of poorly ventilated volume of lung. How much lung surface is not functioning. So we can estimate by dividing TLCA minus VA. Now KCO. What is KCO? This is transfer coefficient of carbon monoxide. Rate of uptake of carbon monoxide from alveoli to blood. Diffusion per unit volume. So say for example, this is volume of gas which is available for transfer. And KCO is the amount of transfer from alveoli to blood per unit surface area. Okay, this is efficiency. So per unit volume, how much gas is transferred from alveoli to blood. So this is reflect both efficiency of alveolar membrane, how efficient alveolar membrane is there for diffusion of oxygen or carbon monoxide. Okay, then availability of blood, how much blood is flowing. Okay, if more blood is there, more diffusion will be there. Okay, and then amount of hemoglobin, more is the hemoglobin, more binding of um, carbon monoxide to hemoglobin. So KCO is amount of oxygen transfer from alveoli to blood vessels and amount of blood in blood vessel and hemoglobin. So KCO depends on these two things, blood and efficiency of alveolar membrane. This is called efficiency index. Okay, while VA is the amount, the surface area of or alveolar volume which is available for gas exchange. Okay, that is VA. So my question is to you that is DLCO upon VA is KCO? Yes or no? Definitely no. These both are related, but they are not equal. Why? Because DLCO upon VA means diffusion per unit volume tells us gas transfer efficiency per unit of lung volume. In 1 unit of lung, how much transfer is there? While what is KCO? KCO is include both. Not only gas efficiency from alveolo-capillary membrane, but also measures amount of blood in the lung capillaries. Okay, amount of hemoglobin. So KCO depends on gas exchange and blood and hemoglobin. So KCO is not equal to DLCO upon VA. Both are related, but not equal. This is commonly asked question. So DLCO upon VA is focused on gas transfer per unit of lung volume. In 1 unit of lung, how much transfer is there? That is DLCO upon VA. While KCO consider both gas transfer and blood availability. So more is the blood, more is the KCO. So giving broader picture of lung function. So you remember DLCO by VA and KCO is both difference. So now what is the relation between VA and TLC? I told you TLC is total lung capacity. If we remove dead space, that is VA. Okay. In normal adult patient, VA upon TLC is 85 to 90%. Okay. So value significantly below this less than 85 suggests that gas mixing impairment are likely contributing to low measured DLC. Okay, if VA is less, very less than that of TLC, it means there is ventilation defect, VQ mismatch because of airway obstruction. Okay, so by measuring VA upon TLC, we can have idea whether diffusion defect is there or not, whether VQ mismatch is there or not. Okay, so the condition which increases DLCO. So you have to remember DLCO contain both alveolar volume, that is VA, and KCO. Okay, so increased DLCO is depends on KCO because VA means lung volume is not increased normally. So if you find increased DLCO, it would be due to extra pulmonary cause like high altitude. Okay, high altitude means mountain. In mountain, what happens? There is less oxygen concentration in environment. So partial pressure of oxygen is low. Oxygen is less, carbon monoxide is same. There's less competition of carbon monoxide with oxygen for hemoglobin binding. So more carbon monoxide will bind to hemoglobin. There's no oxygen. So there will increase DLCO. Why? Because of increased KCO, not because of VA, increased KCO. Like asthma, especially acute exacerbation. In acute exacerbation asthma, there's increased pulmonary circulation, which will increase DLCO. Polycythemia, more hemoglobin. Hemoglobin is 18, 19, 20. So more hemoglobin, more binding of carbon monoxide to hemoglobin. It will give increase KCO and DLCO. Severe obesity, mechanism don't know. Left to right cardiac shunt. So blood is coming from left to right ventricle. From right ventricle, more blood will go to pulmonary circulation. So pulmonary circulation will get increased. Because of more pulmonary circulation, there will be more transfer of carbon monoxide from alveoli to blood. Muller maneuver, I have told you mechanism. Supine position, I have told you. Bronchodilator use, because bronchodilator use decreases VQ mismatch, increase ventilation, which increase DLCO. Bronchodilator use, mild left heart failure. Mild left heart failure, there will be increased pulmonary circulation. Okay. Pulmonary hemorrhage, lot of blood is there in alveolo-capillary membrane, interstitium. So more blood, more hemoglobin, more binding of carbon monoxide. So all these things increases KCO, not VA, which causes increase in DLCO. Now condition with decreases DLCO with normal spirometry. Once spirometry is normal, it means normal VA is there. Normal spirometry means alveolar volume is normal. The problem is reduced KCO. So decreased DLCO because of reduced KCO is seen in anemia. There's less hemoglobin. Okay. Problem in pulmonary vascular disease. There's less supply of blood to alveoli, like pulmonary arterial hypertension, pulmonary embolism, vasculitis. In these, there's reduction in pulmonary circulation. Hepatopulmonary syndrome. It is like a physiological shunt. So blood is not going through pulmonary vessels. Shunting is there. Early ILD. In early ILD, X-ray would be normal, spiro would be normal, but you will find reduced DLCO because of reduced KCO. Smoker, I have told you mechanism, supplemental oxygen. So this will reduces DLCO by reducing KCO. VA would be normal, spiro would be normal, chest X-ray would be normal. Decrease DLCO, restrictive lung disease. So restrictive lung disease, parenchymal restrictive lung disease like ILD, pneumonitis. In this ILD, what happens? Lungs get fibrosing. So fibrosis causes reduction in lung volume. So reduction in VA. Okay. KCO could be normal or reduced. Normal KCO is most common, but reduced in when alveolo-capillary membrane thickness is increases. Say for example in IPF. In IPF, VA is reduced because of fibrosis and membrane also thicken. So it will reduces KCO. Okay. So in parenchymal restricted lung disease, VA will be reduced, KCO could be normal or reduced. Overall decrease in DLCO. If problem is then extra parenchymal, means lung is not able to expand because of extra pulmonary cause like kyphoscoliosis, obesity, neuromuscular disorder. So in that case, VA will be reduced because lung is not able to expand. But alveolo-capillary membrane is healthy. So once alveolo-capillary membrane is healthy, so diffusion will occur from normal site. Okay. So there will be increase in KCO. VA is less, but KCO will increase proportionately. it will cause normal DLCO or slightly reduced DLCO. So you have to remember, if restricted lung disease is because of parenchymal change, it will give reduction in DLCO. If because of extra parenchymal, it will give normal DLCO, but KCO is more. This is commonly asked question in your exam. Now, if spirometry is showing obstruction, airway obstruction. Once airway obstruction is there, say for example in bronchiolitis, cystic fibrosis, with or without restriction like COPD with ILD or combined pulmonary fibrosis emphysema. In this condition, there will be poor ventilation of lung. Means air is not reaching up to alveoli. So it will reduces DLC. What happen in emphysema? Emphysema, there is reduction in surface area because of alveolar hyperinflation. So because of alveolar hyperinflation, there is damage of capillary membrane also. So the area which is damaged because of emphysema, it will have reduced blood supply also. It reduces DLC in emphysema. Okay. Other conditions, for example, pneumonectomy. Pneumonectomy is partial removal of lung. Say for example, there are two lungs. One lung is removed. Okay. So VA reduces because surface area reduces, one lung is removed. But the whole blood supply, whole pulmonary circulation will diverted to normal healthy lung. Okay, so you can imagine there is one lung, but whole blood supply is going through normal lung. So there will increase KCO. So DLCO will decrease because of decrease in VA, but KCO will get increase. The overall result would be slight decrease in DLCO only. Okay, understand? KCO will get increase. Inhalation of toxic gas like alveolitis. So DLCO will get reduced. Loss of lung tissues like post-TB fibrosis. There's reduction of lung volume, reduction in DLCO. Space occupying lesion, pulmonary edema. So in these conditions, DLCO will be reduced. Now interpretation of result. Okay. So interpretation, this is taken from new guideline. New guideline, we are using 5th percentile or lower limit of normal and 95th percentile upper limit of normal. If it is less than lower limit of normal, okay, DLCO is less than lower limit of normal, then we have to check whether reduction in DLCO is due to pulmonary cause or extrapulmonary cause because of VA or KCO. First, we will see VA. If VA is normal, means lung is normal, X-ray is normal, our volume surface is normal, then problem is below the lung. Most common is vascular problem like pulmonary hypertension, pulmonary embolism, vasculitis, or rare condition emphysema with preserved lung volume like early ILD or anemia. Okay. If VA is reduced, means lung volume is reduced. Okay, there's restrictive pattern. Then we have to look for KCO. If KCO is high, VA is less, KCO is high. I told you most common example is pneumonectomy or complete lung expansion. Okay, like neuromuscular dysfunction. In that DLCO may be normal or reduced. But KCO is high and VO is low. And VA is low, KCO is also low or normal. That is emphysema or ILD. Because ILD, there is lung fibrosis. VA will be reduced, but KCO would be normal or low. Depends on membrane thickening. If DLCO is more than upper limit of normal, then upper limit of normal means there's more blood supply. KCO is more because VA cannot be more. KCO is more. In that the condition is obesity, erythrocytosis means polycythemia, alveolar hemorrhage, and left to right shift. So this is how we have to report or interpret DLCO. Remember, if you are asking other PFT, then you can diagnose perfectly. So we start with spirometry. In spirometry, if ratio by FE1 or FVC is normal, more than lower limit of normal. If ratio is normal, there are two conditions, either normal spirometry or restrictive pattern. If normal spirometry, then we should do diffusion study. If diffusion is also normal, means normal lungs. If diffusion is reduced, restrictive means normal lung, but reduced DLCO means problem is there is vasculature because alveoli are normal. So the common cause is pulmonary arterial hypertension, vasculitis, pulmonary embolism. If there is restrictive pattern could be real because of restrictive lung disease or pseudo reduction in vital capacity because of emphysema. For that, we have to do total lung capacity. If total lung capacity is less, it means there is true restriction. If true restriction, then we have to do DLCO. If DLCO is less, then problem is ILD or pneumonitis. If DLCO is normal, then extra pulmonary cause like neuromuscular disorder. Okay. If restrictive pattern but TLC is normal or more, then problem is obstruction. Okay. If there is obstruction, we have to do DLCO. In DLCO, if reduced, emphysema. If DLCO is normal, asthma or chronic bronchitis. So this is how we should combine spirometry, total lung capacity, and diffusion study. So for severity, previously we used to see percentage. More than 140 is high. 75 to 140 is normal. 75 to 60 is mild. 41 to 60 is moderate. Below 40 is severe. But in new guideline, we should use Z score. So we have to remember three things: 1.65, 2.5, 4. So plus 1.65 to minus 1.65 is normal. 1.65 to 2.5 is mild, or 2.5 to 4 is moderate, and more less than 4 is severe. And more than plus 1.65 is high. So we have to remember Z score, by which we can divide mild, moderate, severe. So now let's see real example. So before interpreting any DLCO, we have to check data, whether age, sex, BMI, all have been inserted correctly or not. So all are correct. Then this is, we have to see technique, tidal volume. Now after tidal volume, patient has to exhale completely up to RV. But you can see patient has not exhaled completely. Okay. Then after complete exhalation, patient has to take deep breath within 4 seconds, then hold for 10 seconds, then exhalation. Okay. So technically, if you see, this procedure is not correct. Why? Because patient has not exhaled up to RV. Okay. If you see value, if you want to interpret it, then we have to see first BHT, breath holding time. So how much it should be? 8 to 12 seconds. So how much patient is having? 13. It is more than required. Okay, 13 is good. Then above value is without correction to hemoglobin. Below value DLCO and KCO is corrected for hemoglobin. So this person hemoglobin is 11.7, means less than normal predicted. Okay. For this hemoglobin, DLCO should be 4 should be 8.22 and patient DLCO is 4.52. This is 56%. If you see in Z score minus 3.11. So 1.65 to 2.5 is mild, 2.5 to 4 is moderate. This is moderate reduction in DLCO. So reduction in DLCO is due to either VA or KCO. So we have to look for VA. So VA is 64%, VO is less. Okay, VO is less, and KCO is 90%. Z score is normal. Okay, so in this person, DLCO is less, VA is less, means cause is pulmonary cause. Okay, if you see carefully, TLC, total lung capacity, is 66% reduced. So reduced TLC means restrictive lung disease. DLC is reduced, VA is reduced. This is case of restrictive lung disease, most commonly ILD. And Z score is 3.11. So moderate diffusion defect test of ILD. Okay. In this report, all is well. Then patient tidal breathing, exhale completely, then inhaled, hold the breath, then expire. Okay. Expression should be within 4 seconds, but it has taken more time. Okay. If we see report, breath holding time is 13 seconds, more than required. Okay. Then DLCO, corrected one. We will see corrected one. C, corrected one. 56% less. So DLCO is less. Then second step is we have to look for VA. VA is also less. Then KCO. This is KCO. KCO is 84% or Z score is normal. So in this condition, DLCO is less, VA is less, KCO is normal. Again, restricted lung disease and TLC is 69%. This pure restrictive lung disease. Example, interstitial lung disease. So in this case, all are correct. Then tidal breathing, patient has to exhale up to RV. Okay. But you can see patient has started inhalation, then stop for a moment. Then again started inhalation. Okay. So inhalation is not smooth. So this is not correct technique. Another thing is patient should take less than 4 seconds for inhalation. But in this case, patient has taken 20 from 28 seconds to 35 seconds, almost 7 seconds. So this is not correct technique. So we should discard this result because it will give false report. So this is falsely normal report. So we can not rely on this report. So in this, patient has taken tidal breathing, then without exhaling, patient hold the breath for 10 seconds. Okay. So patient didn't exhale to RV. So this is false report. This is incorrect technique. So we should not interpret this report. Okay. This is last report. So we have combined all three tests. So in spirometry, this is mild obstruction because ratio is slightly less than 70%. Okay. TLC is also almost normal. This is not emphysema or mild emphysema because TLC is marginally raised. But if you see DLCO is 50%, 55%. This is significantly reduced. And KCO is very less, 46% only. So spirometry is slightly emphysema, but DLCO is very less as compared to normal. So this is case of emphysema with probably pulmonary arterial hypertension because KCO is reduced disproportionate. So this is case of emphysema with PAH. Okay. So take home message, diffusion study and transfer test both are same. Correct term is transfer test. DLCO is not only to be used for ILD, but we have to do DLCO in other conditions like to diagnose early emphysema, drug-induced ILD, drug monitoring, other tests, other indication. DLCO by VA is not KCO. Both are related but not same. Should be interpreted in combination with other pulmonary function tests like spirometry and total lung capacity to diagnose patient fully. Interpreting DLCO is easy if you see this lecture very carefully. So thank you very much. So if you like this video, please like it, share with your friends. See you with another video. Thank you very much.